Welcome to this webinar, which is on psychiatric history and mental state examination. This is part 1 of 4. I'm Dr. Krisha Patel, and I'm the mental health lead for the company. So the objectives of this session are to understand the components of a psychiatric assessment, and we'll break that down into the history taking, the mental state examination, and the risk assessment. We're also going to understand how to record your assessment. And we're also going to understand how this information is used to make a psychiatric formulation, a diagnosis or a provisional diagnosis, and a subsequent management plan. Each part is going to be approximately 20 minutes long, and it's designed to be interactive. So at various points, you will be asked to pause your video so that you can write down your thoughts or discuss them in small groups. So this training can be done on your own or can be done in small groups of, say, 2 to 5, with one person acting as the facilitator of the session. So psychiatric history. So when it comes to mental health diagnosis and mental health problems, it all comes down to the psychiatric history and the mental state examination. There's no simple blood test to diagnose depression. There's no simple MRI scan that will diagnose schizophrenia. Everything comes down to the psychiatric history and the mental state examination. So when I'm doing a psychiatric assessment, I'll start off by thinking about a few background details or background information. If I'm working in the police custody setting, let's say a sergeant has referred someone to me, a 35-year-old male who's presented or who's expressed some suicidal thoughts. So I'll think about those background details, 35-year-old male, referred by the police sergeant with suicidal thoughts. I might also look back at other police records or other previous healthcare assessments that have been done on that client or any other notes that may be available. I'll then move on to the presenting complaint, which is the reason they've come to see you in the first place. So in this case, it's suicidal thoughts. And I'll then move on to the history of the presenting complaint, which is your opportunity to find out in more detail about their presenting complaint. So your opportunity to find out in more detail about the suicidal thoughts. I then move on to the past psychiatric history, the past medical history, the current medications and allergies, their family history, their personal and social history, the drug and alcohol or substance misuse history, their forensic history, their pre-morbid personality, and their collateral history. This is the order that I use. There's no strict order that you need to do a psychiatric history. One thing about psychiatric assessments is they take a long time. So if I was to see a new patient, and this is the first time I'm assessing them, doing a psychiatric history, doing a good mental state examination, doing a good risk assessment, and then recording all that information in a nice logical order in the medical notes takes, I would say, between 1 to 2 hours. Sometimes it's less, sometimes it's more. Obviously, in your setting, when you're the healthcare practitioner in police custody or the nurse working in sexual assault referral centre, you will not be doing a full psychiatric history, a full mental state examination, and a thorough risk assessment on everybody you meet. You will be selective about the things you do, and you will be adapting your history taking to the client in front of you. Nevertheless, it's useful to know a little bit about all the components of the psychiatric history, just in case there comes a time when you need to do a little bit more for your patient and find out a bit more about their psychiatric history. And in those cases, it is relevant to know all the components. Presenting complaint. So this is the reason that the client has come to see you in the first place. So what has the client come to see you about? Now, it's best to write down what they say verbatim. So that means in the patient's own words, what have they come to see you about? Is it depression? Is it self-harm and suicidal thoughts? Is it hearing voices or feeling paranoid as if people are after me? Is it feeling anxious or experiencing flashbacks? After the presenting complaint, we move on to the history of the presenting complaint, which is your opportunity to find out in more detail about what they've come to see you about. So I start off with some open questions to get them to talk a little bit more about the reason they've come to see me. Once I've asked some open questions, I might need to find out some specific information. So I'll move on to a few closed questions to find out some specific details. I want you to imagine that somebody has come to see you as the healthcare practitioner with the presenting complaint of low mood. I'd like you to pause the video and write down 4 things you would ask them about their low mood in the history of the presenting complaint. So you can either do that on your own or discuss in your small groups. So the type of questions you might have asked are, how's your mood been lately? That's a nice open question, giving the patient the opportunity to talk. You might want to ask about other symptoms, because a diagnosis of clinical depression is not based on low mood alone. In general, other symptoms need to be present for a diagnosis of clinical depression to be made. So those other symptoms include lack of energy or loss of energy. The patient may present with tiredness or fatigue instead of saying they've got low energy. There may be loss of interest in activities they used to enjoy. So you need to ask them, what kind of things did they used to enjoy doing, whether that was reading, watching TV, meeting their friends, and do they still find pleasure in those activities? Do they still want to do those things? And loss of interest in things they used to enjoy is called anhedonia. You might then want to ask about sleep, appetite, and weight loss. In typical depression, people find it difficult to sleep and have real trouble getting to sleep, or they can wake up early in the morning and find it very difficult to get back to sleep. Typically, people lose their appetite, and that might lead to subsequent weight loss. Although I should also mention, some people with depression report sleeping too much, eating too much, and therefore weight gain. They may also describe difficulty concentrating, so you could ask if they're still able to read a book or watch the news and able to concentrate on that. Some people describe feeling guilty and hopeless about the future. And if anyone presents with a psychiatric condition such as depression, we always need to screen for suicidal thoughts, and that forms part of our risk assessment. We also want to know how long things have been like this. How long has their mood been low? To make a diagnosis of clinical depression, symptoms generally need to have been present for most days over at least a 2-week period. And then we might want to ask if there's anything that has happened recently that might have triggered their low mood. Is there a bereavement? Is there a job loss? Sometimes people will be able to identify a trigger, and sometimes they won't. Now I want you to consider someone who's come to see you about suicidal thoughts. So their presenting complaint is suicidal thoughts. I want you to think about maybe 6 or 7 questions you would ask about their suicidal thoughts in your history of presenting complaint. Again, I'd like you to pause the video and write your thoughts down or discuss them in small groups. So when it comes to suicidal thoughts, it's not just about the presence or absence of suicidal thoughts. We need to find out more about what they mean. So it's not just yes or no. And I like to think about suicidal thoughts as being on a spectrum. So on one end of the spectrum, someone might say they have suicidal thoughts and suicidal ideas, but they may be fleeting and rapidly dismissed. That person may fear those suicidal thoughts and really worry about acting on those suicidal thoughts. They don't want to act on those suicidal thoughts. They don't have any plans, they haven't made any preparations, and there's no intent to act on those suicidal thoughts. On the other end of the spectrum, there may be someone with suicidal thoughts that have been worsening, that are really intense and present all the time. There may be real intent to act on those suicidal thoughts and a real desire for suicide. They may be ambivalent about life and death. They may not fear these suicidal thoughts at all. They may have researched methods or made plans and preparations. Anyone can lie anywhere along this spectrum. And it's our job as healthcare practitioners to find out and explore in detail what they mean about suicidal thoughts and consider where they lie on the spectrum. So I like to start off with some gentle conversation starters, things like, how do you feel about the future? Have you thought life is not worth living? Have you ever wished you could go to bed and not wake up? These are the sort of opening questions that gives the patient permission to talk about suicidal thoughts if they've never talked about them before. Then I want to ask a bit more about the suicidal thoughts. I want to know if they've thought about ending their life, if they've got active thoughts about ending their life, if they're thinking about suicide. I want to know if they've made plans or preparations, have they thought about methods, do they have access to means? So by plans and preparations, you have to consider, have they perhaps made a will or settled their financial affairs? And when I write thought about methods, you have to think about, have they researched any methods? Have they bought a rope? Have they stockpiled medications? And access to means. So as an example, you might see someone who's expressed suicidal thoughts and they said that they've thought about ending their life by shooting themselves. In this scenario, we have to follow up that question with, do you have access to a gun? Is it your own gun? Is it somebody else's gun? That is imperative when we're thinking about restricting access to means, when we're thinking about a safety net plan for that particular patient. If they've thought about perhaps taking an overdose of medications, you need to ask them, have they thought about which tablets they would take? Do they have tablets at home? Have they stockpiled medications that they're currently being prescribed? Restricting access to means is going to be part of that safety net plan. So in the first example of the firearms, part of the safety net plan would be to remove that firearm from the home, and the police may need to do that. If somebody has mentioned that they've stockpiled medications at home, one thing we would be advising is for those medications to be kept away in a locked cupboard where they don't have the key, or somebody else keeping those medications for them, and perhaps asking the GP to only prescribe a week of medications at a time. We also want to know if they've tried to hurt themselves before. Have they done so recently? Have they had a recent failed suicidal attempt? And how do they feel about that now? Do they regret doing that? Or do they really still feel like they want to hurt themselves? And do they have ongoing suicidal intent? We want to know a little bit about the severity and the frequency of the thoughts. Are they becoming more frequent and more severe? And some people may describe their suicidal thoughts as being present all their time, their whole life maybe. It's important to know in these patients whether they feel their suicidal thoughts are stable, or have they been deteriorating and worsening recently, becoming more intense. Now I want you to consider somebody with the presenting complaint of self-harm. What type of questions would you ask them in the history of presenting complaint? And again, I want you to pause the video and discuss this in your small groups. How do you self-harm? In this slide, I've shown a picture of tablets suggesting overdose, but obviously there are many different ways people do self-harm, from head banging, tying ligatures around their neck, cutting themselves. There are many different ways people self-harm. But we really want to know why they self-harm. There are many reasons why people self-harm. For some, it's their coping mechanism, and it's the only way they've learned how to cope with their emotional distress. For others, it may have been a suicidal attempt that wasn't successful. So we need to explore that with our patients. We need to explore the motivation behind the self-harm and the intent behind it. We also want to understand how they felt immediately before they self-harmed, and how they felt during the self-harm, and how they feel about it now. Do they regret their self-harm attempt? Do they still feel like they want to hurt themselves? Do they feel upset that the suicidal attempt was not successful? So this takes us to the end of part 1. In this section, we've started to take a history, and we've really focused on the presenting complaint and the history of the presenting complaint. In the next part, we're going to move on to the rest of the history taking.